Thank you very much, Zeb. This is a nice word that you used to introduce me. I want to share with you my co-workers at the Hôpital Fortune. You have Professor Ayubi, who is well known on the uterine transplantation, Professor Friedman, also extremely well known, and Professor Bouchard. Now, we are talking about endometriosis and infertility, and endometriosis being now a new indication for IVF. IVF was originally conceived for tubal infertility. Then came ICSI, and ICSI are now allowed to treat male factors, and ART also allowed to offer egg donation. And now we're talking about a new indication for ART, which is endometriosis. And I will convince you that endometriosis is well treated by ART. When we're talking about infertility, of course, endometriosis is also a source of pelvic pain, and this is a different issue. In essence, you have a conflict of interest between the two objectives: to treat pain, and you have to block ovarian function, and to allow fertility, and you need ovarian function for that. So it's important that early on in the process, you decide with the patients their primary objective, and often they will tell you that they want to have a baby and then treat the pain, which is when ART comes into the picture. Endometriosis is a new indication for ART, and I'll try to convince you of that. Now, what is important is to realize that there have been 4 new hallmarks in the understanding of endometriosis in the pathology, which impact on how we handle endometriosis now. It's important to go over those findings. First of all, there is a new approach for diagnosing endometriosis. Classically, endometriosis was a surgical diagnosis, and there was endometrial biopsies performed during surgery. But today, with the success of ART and the fact that women come for reproductive treatment later on in life, there is currently no diagnostic laparoscopy performed anymore, and rather we go for ART first. So therefore, if you only count on surgical diagnosis, you underscore the incidence of endometriosis in infertility and in ART in particular. So we really have a need for new approaches for diagnosing endometriosis, and we have to count on imaging-based approaches, because surgery is not performed due to the success rate of ART and due to the fact that we come later in life for ART treatment. Then the second point is a toxic pelvic condition, whereby the pelvic cavity is the site of inflammation, and this actually alters oocyte and embryos, but as we will see, only in vivo conditions, not in ART. Then endometriosis impact on the utopic endometrium, but we have ways to circumnavigate this issue with ART, and we will convince you of that as well, I hope. Now, the effect of ovarian reserve, this is renewed. Now we understand that surgery is likely to impact on ovarian reserve. As you will see, surgery is even worse than the disease itself. Now, let's talk about the pelvic condition and the impact on oocytes and sperm and embryos. We wrote an article on this in 2018, but this is essentially the situation that you have in the pelvic cavity. Due to inflammation, you have a toxic condition whereby the even temporary exposure of oocytes will alter the development of embryos and cause infertility. And this is the way probably endometriosis is most likely impacting on natural conception. This is the impact of toxic pelvic cavity on oocytes that are ovulated and the impact on the embryos formed in the distal end of the tube, as well as the impact of the toxic environment on sperm. But the core of the message is this: with IVF, you bypass the pelvic cavity because the oocytes are being aspirated without contact with the pelvic cavity and taken into ART process until the embryos are transferred back in the uterus. And we'll talk about receptivity. So therefore, what you have to understand is that ART bypasses one of the primary factors whereby endometriosis alter fertility, bypasses the pelvic cavity. Now, proof of that is provided by a work we conducted with Caroline Junot and Richard Scott and ourselves. We worked on endometriosis and provided evidence that actually oocytes and in consequence embryos are unaltered in case of endometriosis. This is the results that you have. This is the aneuploidy, and as you see, aneuploidy increases with age. There's nothing new in this. However, what is important to realize is that there's no difference in aneuploidy rates between women in light blue who have endometriosis and dark blue who do not. They are infertile without endometriosis. And you see that there is no difference in aneuploidy. So therefore, the concept that endometriosis alters oocyte quality is true, but only in vivo. And there's been a lot of papers written on the impact of endometriosis on oocytes, but ART bypasses that. Oocytes retrieved in ART are unaltered. And this is an important message to pass on because this actually is one of the primary bases for making endometriosis an indication for ART. Now, this is the work by Lauren Bishop and Kate Devine, Mika Hill, and Alan DeCherney, and they actually have shown evidence that endometriosis does not impact on live birth rates in the case of frozen transfers of euploid blastocysts. Now I'll come back to that because actually this is an important point that actually shows lack of impact on receptivity, provided that you have a transfer in the context of estradiol and progesterone, HRT, if you will, cycle, which actually blocks ovarian function. We'll come back to that when we talk about endometrial receptivity. Now, the effect of surgery on ovarian reserve. Surgery is ovarian reserve, but what we realize now is that endometriosis has a little impact itself. And surgery for endometriosis is far more harmful than endometriosis itself. And so surgery is best avoided when you envision ART. This is the work of Hamdan that actually looks at the impact of endometriomas. Endometriomas do not alter ART as we first thought. Surgery for endometriomas does, but endometriomas themselves do not harm ART. This is the work of Hamdan, and you see here the live birth rate, and the real impact of endometriomas is on the cancellation rate. Yes, there is a certain degree of impact on ovarian reserve, not as much as surgery, and this leads to cancellation rate. But once you get the embryos, once you get the oocytes, and you get the embryos, then the clinical pregnancy rate, the live birth rate, and the risk of spontaneous abortion, is not markedly increased in case of endometriosis. Again, saying that oocyte quality is not altered. This is a core message of this presentation. Oocyte quality is not altered. Now, there were fears that ovarian stimulation for ART would actually flare the disease. This is not really the case. This is not really the case. And let me show you evidence of that. This is work that we did when I was at Cochin. Pietro Santulli is the primary author of this work. And this is what we had. This is what we had. We have here two patients with ART in blue and in green, without endometriosis, or with and without endometriosis. And you see that those are all kinds of subjective symptoms of discomfort. And you see that the symptoms decrease because patients were all synchronized with the pill, which, by the way, synchronization with the pill is something that is actually applied by lots of groups, in particular by all the 13 best ART centers in the US. And as you know, the US do extremely well in ART. So the pill actually decreases symptoms both in women with endometriosis and in controls, but the stimulation itself, there is no flare. There is no flare. This is against what had been written in ovarian stimulation and IUI. Now, the reason for a difference between the work that we did at Cochin and the concept that ART flares the endometriosis is linked to the fact that in COS IUI, you have the release of massive amount of estradiol in the follicular fluid at the time of ovulation when you do your insemination. Whereas in ART, and this is an important concept, there is no ovulation. There is no ovulation because you aspirate the follicular fluid and you get the oocytes, but the content of the follicular fluid, which has concentration of estradiol in the 10 to 20,000 picogram per ml, the content of estradiol is not released in the pelvic cavity where the lesions are, and ART avoids ovulation. This is an important message. So if you have endometriosis, please do not do COS IUI. Go on for ART. ART does not flare the disease, contrary to all the publications that indicated that it does in case of COS IUI. Now, you do ART in case of endometriosis, you also have an interest in freezing all oocytes during transfer. In the work before by Santulli, we had used antagonist protocol and triggered ovulation with the agonist. This actually allows to avoid cyst formation. It is a good practice in case of endometriosis. And you see here the pregnancy rate with the fresh versus the frozen. And you see the frozen is markedly higher. And this is the work of Bourdon et al. Now, our hypothesis is that ovarian function actually has a negative impact on the eutopic endometrium. It is not estradiol. It is actually ovarian function. And every measures that you can take to block ovarian function, be it the GnRH agonist, be it the oral contraceptive pill, will actually avoid the eutopic ovulation that in endometriosis. And those alterations include the local production of estradiol in the endometrium, activation of CYP19, as well as resistance to progesterone. This is under the influence of ovarian function, not under the influence of hormones. Actually, blocking ovarian function will actually prevent that. Gram per ml, the content of estradiol is not released in the pelvic cavity where the lesions are, and ART avoids ovulation. This is an important message. So if you have endometriosis, please do not do COH IUI. Go on for ART. ART does not flare the disease, contrary to all the publications that indicated that it does in case of COS IUI. Now, you do ART in case of endometriosis, you also have an interest in freezing all oocytes during transfer. In the work before by Centuri, we had used antagonist protocol and triggered ovulation with the agonist. This actually allows to avoid cyst formation. It is a good practice in case of endometriosis. And you see here the pregnancy rate with the fresh versus the frozen. And you see the frozen is markedly higher. And this is the work of Bourdon et al. Now, our hypothesis is that ovarian function actually has a negative impact on the eutopic endometrium. It is not estradiol. It is actually ovarian function. And every measures that you can take to block ovarian function, be it the GnRH agonist, be it the oral contraceptive pill, will actually avoid the eutopic alteration that in endometriosis. And those alterations include the local production of estradiol in the endometrium, activation of CYP19, as well as resistance to progesterone. This is under the influence of ovarian function, not under the influence of hormones. Actually, blocking ovarian function will actually prevent that. And as you will see, not just with the agonist or the pill, but also with estradiol and progesterone as done for transferring frozen embryos, particularly euploid embryos. So again, ART has a new indication, endometriosis, but you have to use, it's preferred to use the agonist trigger, but you have to do freeze-all and deferred embryo transfer. Now, once you decide to go for IVF and you do not perform surgery, therefore you're going to do surgery in case of endometriomas in place. And therefore, the question that you're going to ask yourself, is this dangerous? And the answer is hard to actually provide precise. We did a research at Cochin and provided with an article that actually says that the risk of tubovine abscess in case of endometriomas at the time of IVF is both under and over-reported. How is that possible? Let me try to explain to you what we did. What we did is we looked at all the cases of women had been hospitalized at Cochin for a 4-year interval with a diagnosis of pelvic PID, pelvic inflammatory disease, as well as endometriosis on the insurance records. And we had 10 of these women over 4 years, but only three of them had ART. Now, we realized that a pelvic infection, PID, occurs in case of endometriomas, even in the absence of ART. So therefore, some of the cases are reported long after ART and over-report. As well, it is underreported because this is the 3 cases that we had in France. We have to report to the supervising system the complications of ART if they occur within 2 months of ART. And as you see, the first 2 cases occurred within 2 months and were reported. But this number 3 case occurred 100 days after ART and was not reported. Is this inflammation that occurred linked to endometriosis and ART? It's hard to tell. Hard to tell. Now, as we said, endometriosis is a new indication for ART. And if you look at the options that you have, which is surgery versus ART, you see that surgery has a place. I'm talking about infertility. We're not talking about pelvic pain. Pelvic pain is often managed medically, but if that fails, you have to go for surgery. Now, we're talking about infertility, and in case of infertility in young women, when when the sperm is good and tubes are fine, you can do surgery for natural conception. But surgery is not helpful for ART. So therefore, you realize that in the majority of cases, the women that we see in infertility treatments who are above the age of 30 and around the age of 35 most of the time, ART is the primary indication for treating infertility linked to endometriosis. Now, at the end of the spectrum, you have women who are in the older age bracket who have failed ART, and in these cases, you may perform endometriosis, particularly if pain or if you want to remove endometriomas for the risk of cancer. And sometimes you do have pregnancies occur, but this is after failing ART. Now, we're getting to the end of this talk, and I want to really emphasize how we work up women with infertility and endometriosis. But first of all, we have to know that they have endometriosis because we don't do surgery. Diagnostic laparoscopy is not part of routine workup anymore. So therefore, you have to rely on imaging-based approaches, both ultrasound and MRI, to actually identify endometriosis. This is part of the workup. You have to look for symptoms. You have to ask for symptoms. Do you have pain at the time of menses? Particularly at the time of adolescence, did you miss school when you had a period, when you were an adolescent? And if those symptoms are present, you have to go and search for endometriosis by imaging-based approaches, because we don't do diagnostic laparoscopy. And we don't do diagnostic laparoscopy for 2 reasons. Again, because ART works very well. And second of all, because surgery is not indicated in those women. We go for a strategy which is called ART first. This is how it's done today. If you don't look for endometriosis by imaging-based approaches, you under-evaluate the incidence of endometriosis. There have been studies conducted by SART in the US with incidence of 11% in women undergoing ART, which is totally wrong. The incidence in women who are infertile and women who undergo ART are mostly infertile is about 40%. So if you don't look for endometriosis, you under-evaluate its incidence. And if you under-evaluate incidence, you don't take the measures that are necessary. So the choice between surgery and ART is based on age. As I said, in very young women, you might consider surgery, provided that ovarian reserve is good. Not always the case. Provided there are no two factors, and provide that the sperm of the spouse is compatible with in vivo fertilization. Why? Because surgery is meant to allow natural conception for the next 12 to 18 months, and you have to have time to spare for natural conception. And then the chances of conceiving naturally are about 50%. Please do not do ovarian stimulation and IUIs if you opt for surgery while you wait, because it is useless. It actually increases the risk of flaring the disease. If age doesn't permit, if ovarian reserve doesn't permit, if there is a tubal factor, and if sperm is not good enough, then you opt for ART. And in this case, please do not do surgery before ART. It doesn't help. It doesn't help, and it can hurt. Please go for what is called now segmented ART with freeze-all and deferred embryo transfer. Is this a rule that is absolute? Of course not. There are exceptions, as with all rules. And the exceptions are, if you opt for ART, but you find that there are hydrocephalus, you have to remove that because it actually alters ART results by about 50%. If you have a very large endometrioma, what is very large? Well, it's up to assessment. It's essentially if you can't access the follicles. If the endometrioma is very large, but you have enough follicles on the other side, don't touch it. If you can't access the ovarian follicles for the ovarian stimulation, you might consider surgery. So, time to really go toward the conclusion, and I want to emphasize the fact that there are 4 new hallmarks in the context of infertility and endometriosis. Again, not talking about pelvic pain, but infertility. There are new approaches for diagnosing endometriosis, and it is important because we do not do routine diagnostic laparoscopies anymore. The concept of toxic pelvic condition and its impact on oocytes and embryos. We know from IVF that even a very short contact of oocytes and embryos with a toxic environment will alter embryo development and may actually even cause miscarriages. This occurs when ovulation takes place naturally and the oocytes, the sperm and the embryos are exposed to the toxic pelvic condition that prevails in the pelvic cavity. IVF, however, bypasses that by getting the oocytes without exposing them to the pelvic environment. We also have learned that the endometriosis has a negative impact on the utopic endometrium, but this is not dependent upon hormones, but on ovarian function, 2 factors that we don't truly understand. But we know that if we block function, those effects are prevented. If you block it with agonists, with the pill, but also if you block with the estradiol and progesterone cycles that are used for priming the transfer of frozen embryos. So please do a segmented ART in this case. We have also learned that endometriosis, contrary to what we thought before, does not alter ovarian reserve as much as we thought, but surgery for endometriosis is more harmful than the disease itself. So in the end, the conclusion of this talk that endometriosis is a new indication for ART, just as male factor with ICSI became an indication, as well as donor egg became an indication for women whose ovarian function has failed. So ART was conceived for tubal infertility, but now endometriosis is one of the new indications. With this, I would like again to present my co-workers at Hôpital Foch, with a special mention for Professor Jean-Marc Ayoubi, who is the chairman and a great supporter of all the work we do there.